cardiology topics. So thank you very much for joining. I'm Tariq Rambatla, cardiologist with Baptist Health Medical Group, MCVI. And today I'm going to be talking about chest pain in the younger patients. Disclosures. I have no disclosures to report. Now the objectives. First is to identify chest pain syndromes in the younger low-risk patients. Figure out which diagnostic imaging would be of highest yield and value in these types of patients, and what treatment options, if any, we should pursue. So I think first is to start with the case. This is a real case, saw last week. It's a 45-year-old male referred to cardiology for abnormal EKG and chest pain. So his chief complaint is he reports a fullness in his chest. It occurs when he walks, but also feels palpitations when he walks. This also occurs, though, at times when he's just watching TV or lying down. So this is kind of a very common scenario where you have someone with no real risk factors, sort of young, and is complaining of chest pain that has both typical and atypical features. His past medical history, hypertension only, and past family history, his father with CAD, with the stent at 65, so it doesn't really meet criteria for premature CAD, but it does run in his family. Social drinker, and his only real medication is losartan, 25 milligrams daily for stage 1 hypertension. On physical exam, his vital signs, his blood pressure was elevated, 165/90, heart rate controlled, and this is in the office blood pressure, no home blood pressure ambulatory monitoring log to review. Physical exam, non-contributory, no edema, no overload, JVP normal, no murmurs. Now this is his EKG, and of course it is abnormal. What we see here is we have sinus rhythm, we have a wide QRS, an intraventricular conduction delay, no left or right bundle branch block, but it is wide, and the IVCD is due to LVH. So we see here that there is significant LVH with strain pattern. It meets criteria for R and AVL being greater than 11. It meets Cornell criteria for R and AVL, and S and D3 being greater than 28 for a male. And we see these ST depressions with T-wave inversion. So these are very classic for strain pattern, with the downsloping ST depressions that blur into the T-wave inversion with a reverse check mark. So these are classic for strain pattern and not necessarily ischemia, but certainly right to call it abnormal and lead to further, questions and management changes. So what's the assessment? So first, this patient came in with chest pain, but we need to know and characterize it. Is it typical, atypical, or non-cardiac? That's what we do with all the chest pain syndromes that come in, because they certainly lead to different paradigms if it's typical versus atypical / non-cardiac. And then what's our pretest probability of this patient in itself? Is he low risk, intermediate risk, or high risk? Because that will certainly decide what kind of diagnostic modalities we would use and treatment, and overall how we would approach this patient. So what's the plan? So in general, we'll get labs, we'll get imaging. The labs, certainly for any patient who I'm trying to assess ASCVD, atherosclerotic cardiovascular disease, I'll get a lipid panel, an A1C, a complete metabolic panel to assess LFTs also, TSH, and a CRP. There are plenty of studies and evidence of elevated CRP and inflammatory markers being a worse prognosis and increased risk for inflammation and CAD. Then imaging. So that's not all the imaging I ordered. These are our options. So echo, pretty routine after EKG. We have options for echo. We have options for CT, coronary artery calcium score, which is non-contrast. Stress test, which could be either just exercise tolerance test with EKG only, exercise or pharmacologic myocardial perfusion imaging, which is a nuclear stress test, and or stress echocardiogram. We also have the option for CTA and for CAT. So what should we do? So for this patient, this is what I ordered. Echo really didn't need, but ordered it anyhow. But first, of course, we're going to get blood work. I want to know what his LDL, what his lipid panel is. I want to know if he has prediabetes, what his A1C is, and again, TSH, CRP, all helpful. Echocardiogram, it's completely indicated for this patient with abnormal EKG, LVH, and uncontrolled hypertension to assess the level of concentric hypertrophy, see if there's any underlying remodeling, any reduced EF, or make sure it's preserved EF, but certainly I want to see the extent of his cardiomyopathy and the LVH. So now what do we do to assess his overall ASCVD risk or a presence. So a CT coronary artery calcium score is very, very helpful in this patient. He's not on lipid-lowering therapy yet, and we're pretty positive his LDL will come back elevated, but we're not sure. But even if it's intermediate, the calcium score is really what we would determine whether this patient needs statin therapy or not. Because if someone has an elevated LDL and his LDL comes back at 100, he might not need statin therapy at this particular time. But if he has a calcium score of 1 or above, he does need statin therapy and he should be treated. So it's always good to establish a baseline with calcium score if someone has not been started on lipid-lowering therapy already. If they have already been started on statin therapy, then really a calcium score should be ordered, because if the statin is doing its job, it's going to lead to some calcification and chronicity of the plaque that's underlying. And oftentimes, actually, calcium scores go up with proper statin therapy. So that's why calcium scores should never be checked once the score is 1 or above. Now with stress test, what type of stress test do I want to do here? So an exercise tolerance stress test, just EKG, would not be helpful in this patient other than assessing his exercise tolerance, which is helpful. But his EKG is uninterpretable because of the baseline ST depressions and T wave inversions. But if you add on the myocardial perfusion imaging portion, then we can assess for stress-induced ischemia. I still did an exercise myocardial perfusion imaging because I wanted to get his exercise tolerance. I wanted to see if his symptoms are truly with exercise or if they support my suspicion that they were nonspecific and atypical. So if he's able to do a sufficient amount of exercise on treadmill, doesn't have reproducible symptoms with exertion, then already we know that his chest pain was not typical and most likely was not from angina. So this is what I ordered, labs and my imaging. Now, you might ask why I didn't go straight to CTA. The issue is it's often not approved. CTAs are great, and they are appropriate for appropriate use criteria for low to intermediate risk patients with chest pain, but it's very often not approved by insurances. It takes a long time to get often these pre-auth or prior imaging and then CTA, and just the time it takes to get it. This can be done much quicker, faster, and also more affordable for the patient. And in this patient, it's completely appropriate. I'll get, in fact, the same amount of information or actually more information with the functional part of the exercise treadmill portion. So results, his lipid panel was high, 155. His A1C was in the intermediate pre-diabetes range. His echocardiogram showed what we suspected, preserved EF, but moderate LVH, supports the uncontrolled risk factors and uncontrolled hypertension. And the exercise MPI, he made it to stage 4 of Bruce protocol, 13 minutes with and he had to stop with fatigue. He had no chest pain with exertion. And then the imaging portion showed no rest or stress-induced perfusion defects, and his calcium score was 0. So what does this tell us? Now this gave us great information. His chest pain, we know, was really not exercise-induced. It was atypical, and that was great information. Also, being able to do up to past stage 4 of Bruce protocol portends a really good cardiovascular prognosis. So we have all of that prognostic information. And then with his calcium score of 0, we also know that he doesn't have any chronic underlying plaque. Yes, there's always the possibility, especially in a young person, to have soft plaque that hasn't yet calcified, that the calcium score won't pick up. And that's always a possibility. But there are, which we'll go over later, good data that shows that a negative calcium score has a pretty good sensitivity and it's quite good at ruling out obstructive disease. So the combination of all that imaging together replaces a CTA, or is actually more than a CTA, but really gives me functional and anatomic information. So my plan for this patient, started him on Lipitor 20. He was agreeable. Technically, maybe you could give him a trial of diet and exercise to try to bring his LDL down, since his calcium score was 0, but he was agreeable. So, the philosophy is lower LDL the better, and might as well get started early in bringing his lipid levels down to prevent the delay of calcification and plaque. So started him on Lipitor 20, doubled his losartan with, he was a with it patient, and I trusted him in the sense that I recommended ambulatory blood pressure monitoring, and I left it up to him that if his SBP remains above 140, we can double the losartan. Diet, of course, DAS Mediterranean diet, and the A1C didn't start on metformin, recheck in 6 months with diet and exercise. And that was my plan for him. So when we're evaluating chest pain, very important, typical angina versus atypical versus non-cardiac. If it is angina, then we want to make sure that it's not unstable angina and it's stable. And then if it is unstable, that's a different scenario in the hospital assessment of low, intermediate, or high risk unstable angina. So when we're evaluating atypical versus true typical angina, these are the classic descriptors. The three criteria that make it typical are: is it substernal chest discomfort with that quality of squeezing? Is it provoked by exertion or even emotional stress? So is it substernal and squeezing? Is it exertional? And then is it relieved by rest or nitroglycerin? And those are the three criteria that make a typical angina. Now, if it meets just two out of the three, so for example, if it's substernal, but it's not really provoked by exertion or it's not relieved by rest, it might be considered atypical. And non-cardiac is just one, just chest pain, but it's not exertional, not relieved with rest, and it only meets one of the criteria. So essentially chest pain without any true criteria is non-cardiac, and typical is meeting all three. Some other things that increase the likelihood of angina, this is basically the same thing we talked about. Is it exertional? That's really the big component, because if someone has non-exertional chest pain, and it happens at rest or it happens when they're sitting down watching TV, it almost by definition cannot be CAD, because stable CAD is an oxygen supply mismatch. So you need something to either decrease the supply or increase the demand. And in stable CAD, the supply is stable. That's what the definition of stable CAD is. So there has to be something that increases the demand, whether it's physical exertional, emotional exertion, something where the heart's working more and we need more blood flow, and that stable fixed plaque is not able to supply that blood flow. So substernal diffuse pressure heaviness, radiation to the arms and the neck, that's of course very typical. Some have just the neck, just the arms. The other day I saw someone with teeth pain, and that was his exertional teeth pain, which ended up being his anginal equivalent. And then if associated with nausea, vomiting, diaphoresis, that's all just a sign of underlying ischemia. And a very important one is, so these are in high probability patients, but someone who's had a previous MI or stent. If someone's ever had that, asking them what their anginal equivalent is. So for example, if someone comes in with pain that seems atypical, it's not exertional, and they've had a previous stent or MI before, and you ask them, what was your pain prior to that episode? And they say, yeah, it was a substernal squeezing, chest pain, worse when I walked, something typical. And now they come with atypical non-cardiac complaints, then that further supports our diagnosis that it's non-cardiac, because it's not even similar to their previous angina. So things that decrease the likelihood, like we talked about, non-exertional. If it's sharp, that's generally not angina. If it's reproducible, obviously, that it's tender to touch, then that's something of costochondritis. Pinpoint, if they can say it hurts right in this specific location, that's often also not angina. And then, things like if it's positional, worse when they lie down or eating a meal, occurs when they're just sitting down, uncomfortable. All those are very unlikely to be true angina. And then just quickly, which is always important even in young patients, even if they're low risk, but just to make sure there's no unstable features. So something where it's severe pain that starts just out of nowhere, that's can be unstable angina. So basically CCS class 3, which is severe activity limiting pain. And if that even happens within 2 months, that's considered unstable. And then increasing angina and rest angina. So that's a separate patient who already has the diagnosis of CAD, but it's gotten progressively worse with less exertion, or worse with the same level of exertion. Those are unstable features. But now going back to the chest pain patient, on top of identifying whether it's typical, atypical, or non-cardiac, we also want to identify their pretest probability of having true CAD, because that also leads to what type of testing we'll do. So in general, this is a slightly busy slide, but the take-home message for this is any male who's 40 years or above is intermediate pretest probability or higher. Just by being a male and 40 years or above, they are intermediate. There's no male who's 40 or above who's a low probability, just by sex and age. And women, that cutoff is a little bit higher, and they're 50 or above. And if they have atypical or typical pain, then they're a high pretest probability. But women with a non-cardiac pain who are above 50, they are still low risk. So just to say that one more time, men who are 40 years or above with any chest pain, even if it's non-cardiac and has only one of those features, they're still considered intermediate pretest probability. So it's still warranted to do some level of ischemia evaluation. And then why is this important? Because if someone is truly low pretest probability, and that means that they have a less than 5% chance of having any kind of underlying coronary artery disease, then really you can do no further testing, and that's perfectly okay, because the likelihood of a positive is more likely to be a false positive. And then on the flip side, if someone is truly a very high pretest probability, meaning they have a more than 90% chance, so they have typical chest pain, they're male, they're 50 or above, or all the risk factors, those even increase their risk even higher. This is from Duke's database, where they incorporated risk factors, but on top of sex and age. But if they're a true high pretest probability, then you also technically don't need further testing for diagnosis, because you've already made the diagnosis. It's more for prognostication and deciding what kind of treatment options you have. And if someone's a high pretest probability and you get a stress test that's totally negative, the chances are that might actually be a false negative. So that can be some of the pitfalls in doing stress testing on high-risk patients, if you use that to rule out and treat them less aggressively. Okay, this is a busy slide. We're not going to spend any time on it, except for showing that exercise EKG and exercise with nuclear MPI or echo are class 1 indications for patients with intermediate pretest probability of CAD, if they're able to exercise. And if they're unable to exercise, then it's a class 1 indication to do pharm stress because they can't exercise. Other reasons why we have to do pharmacologic stress tests instead of exercise are patients who are paced or have a left bundle branch block, because that left bundle branch block or paced rhythm leads to a paradoxical septal motion that gives you false positives and can look like a false perfusion defect. And without exercise, you're less likely to have that quick movement of septum and lead to false positives. And another thing is, CCTA, one of the reasons that possibly why insurances feel more comfortable declining CTAs is because it's in the guidelines actually that it's indicated if symptoms continue despite a prior negative test, or if the test is inconclusive, or if they can't undergo stress MPI or echo. So although CTAs are approved for low to intermediate risk chest pain, and especially in the emergency department, as an outpatient, it can be quite tough. And that's why they often need other imaging. This is basically a summary of essentially all we talked about. I won't read it again, but at least it's in the slides, just talking about low versus intermediate versus high pretest probability, and how someone with a very low pretest probability, it's not indicated, but intermediate and high it is. Now, I wanted to talk about this. This is some nice data, and it's more and more showing that the use of a non-contrast coronary artery calcium score can be very helpful. Aside from just guiding lipid-lowering therapy, which is true, and that's how it is in the guidelines and how it should be used, there still is some evidence that a negative coronary artery calcium score can really help with chest pain patients and put them in a low likelihood of CAD category. So it can be very helpful in our patient that we just saw, where his pain was very atypical and we suspected non-cardiac pain, and we already had functional testing. So the functional testing plus the anatomic testing really helps us with guiding our overall treatment strategy. So a calcium score is always very helpful, and echo is always very helpful, and that can be done and ordered on almost every patient with chest pain, or even just for risk factor assessment. So prior to even referring to cardiology for someone who has chest pain, abnormal EKG, already getting this process started can help and save a lot of time, and it will always be correct and safe. So now I want to talk about a second case, and I think I have a few more minutes to spare. This is it's the last case. It's a 43-year-old female, past medical history of hypothyroidism, obesity, complaints of chest pain. Chest pain is associated with shortness of breath and palpitations. It occurs at rest, but also with exertion. It has been ongoing for 6 months. It doesn't always happen with exertion. So already now this patient is even less likely to have cardiac pain, and it's a younger female. So already we know she's a low pretest probability. Her EKG is shown here. It has no signs of LVH, has a little sinus arrhythmia, left axis deviation, but no ischemic changes, and nothing too significant here. So what's my assessment of this patient? So it's non-cardiac chest pain. She has a low pretest probability. So on this patient, just labs for risk factor assessment and an echocardiogram. On her, if the labs come back with significantly elevated LDL and not inclined to start statin therapy, I can get a CT calcium score, but I don't have a rush and I didn't need to order it right now. Echocardiogram, for anyone with chest pain, it's not wrong to order an echo just to get a baseline. It's approved. And also for abnormal EKG, it's always good to get an echo just to assess for any underlying cardiomyopathy. And but that's the extent of the workup that this person needs, and she ended up doing well also. Her follow-up, her A1C was fine, her LDL was minimally elevated, her echo was normal, and when she came back, her symptoms resolved. So it's not as interesting of a case, but this is the more common scenario we have where chest pain, where it really just doesn't meet any criteria. It's atypical, non-cardiac, and we have to, we want to be thorough, but we also have to be, we want to be effective providers where we don't order unnecessary testing as well. So lastly, to conclude, we all know this, but it's always good just for a refresher. The alternative diagnoses for angina, so the non-cardiac or non-coronary things, very common, I think, on this side, the costochondritis, the inflammation of the lungs, muscle spasm, all of those things are very common, and I think probably the majority of the non-cardiac pain we see. Of course, GERD and reflux disease, very common. The esophageal GI issues, maybe even spasms, but things that happen when they're just watching TV or lying down, very common. And then panic, yes, certainly can be very common as well. That squeezing pain that usually is driven by emotional stress, but someone without any other risk factors, that's usually, that's a common scenario as well. And then, of course, we always want to think about the very deadly things, aortic dissection, pulmonary embolism, but luckily they're very rare in the outpatient setting. And then pericarditis, that is common also on the same lines of pleurisy. EKG can pick it up, and a true pericarditis with prominent features, even the machine picks it up often. But this can be classic too, with the pleuritic kind of chest pain, recent viral syndrome, and EKG and echo can help with that. But overall, that's it. So thank you very much. Thanks for attending. And I see some questions here. So first question, how specific is CRP if elevated, or would you order cardiac CRP difference in diagnostic probability? So the high sensitivity or any CRP, the reason why it's helpful is it doesn't make a diagnosis, but what it helps you with is getting an overall sense of what that patient's inflammatory state is. So if I have a patient whose LDL is intermediate, but their CRP is very high, that could be a reason to bump someone from a low intensity statin to a moderate intensity statin. That could be a reason to try for a lower LDL goal, even if they don't have a diagnosis of CAD, because we know that from data that inflammation is overall bad, and that's what contributes to CAD, and that's what contributes to unstable plaque and ACS. So if someone has a baseline elevation in CRP, that is a great tool to be more aggressive with their primary prevention. And that's how it should be used. Next question, does primary care practitioners normally order a CT coronary artery calcium score? So it varies. Sometimes we see it, sometimes we don't, but honestly, there's no reason why not. A calcium score is a great tool to be used by primary care doctors and cardiologists. We do the bulk of prevention and preventive care for these patients, and a calcium score is a terrific tool to be used to guide lipid-lowering therapy. It's very helpful for patients who do not want to get on statins. They read about the muscle pain, they read about the complications, and just, unfortunately the media is our worst enemy when it comes to statins, despite how much benefit we know they provide. But if someone's reluctant, oftentimes I'm successful in getting them on a statin if we say, okay, let's order a calcium score. We explain to them the physiology that if you have a calcium score of 1 or above, anything other than 0 is a fail, is a bad score, because that means that they have underlying soft plaque, and already some of it is starting to calcify, because you can't have calcium without some level of plaque, whether it's in the blood vessel wall or in the lumen. So we tell them if they have a 1 or above, that means they're already developing plaque and they're at high risk, and then that's a good way to get them on statin therapy. So yes, primary care doctors absolutely should, and that's the way to utilize it, is to get patients on statins. Now, there's usually, sometimes in the community we see people ordering annual calcium scores. There's no benefit in reordering a calcium score. Once you have a score of 1 or above, and they're on a statin, there's no reason to ever reorder it because the calcium score might go up, and it probably should if statins are doing their job. Now, on the flip side, if calcium score is very high, above 100 or definitely above 400, there's some data and some recommendations to use aspirin. But as we all know, the data on aspirin for primary prevention is still very bleak, and there's no definitive answer there. But that's what I do. So for me, if I have a calcium score that's above 100, I'll also start them on aspirin for primary prevention. And that's my practice. It's not based on definitive guidelines, but I think it's good practice if they have low risk for bleeding. Have I ever had any issues with insurance not approving CT calcium scores? No, because most of the time they just pay out of pocket and it's $100. So if insurance is giving any issue, patients often pay the $100 and they get it done. And it's a one-time test. So I've never had an issue with that. Sorry to revisit, would you recommend a cardiac CRP over a CRP, or does that matter? It doesn't matter. It's just different lab values. So some is high sensitivity, some is regular, and it depends on what's high. But anything that's high on the specific lab that's reporting it means there's inflammation there, and that's all. So a regular CRP is fine. And I hope that I answered that question properly. Oh, there's another one. Do you think there's any utility to ordering a Berkeley panel? I'm embarrassed because I don't know what that is. So I'll get back to you though, Humberto. I'll take a look and do a little lit review and educate myself on Berkeley panel, and then get back to you on that. Okay, I guess that's all the questions there are. But thank you so much for attending. And we're here. We're always available. So any questions or any just curbside questions that you don't want to wait for a true referral, or don't even know if the patient warrants a referral, but you're considering it, shoot us a call or a text. We'll try to give my number out, but 786-774-2340. But yeah, we're always available. Honestly, I think anyone from our group would be happy to do any curbside help. And we also have a curbside number that's manned daily that you can actually call and get, and a cardiologist will pick up the phone and just field any curbside questions, interpret an EKG for without identifiers, anything like that. So we're here to help, and thank you so much for attending. I think that's it.